what are caregivers saying? Very important part of this equation. And this was a similar study to the one I just shared about patients and nephrologists, but this one looked at caregivers. And this could have been friends, family, anyone that identified themselves as a caregiver for somebody with kidney disease. And three major themes emerged from a study that looked at caregivers. One is that the role changed over time. Initially, somebody might have been going to appointments, and a caregiver may have had no idea that they even had kidney disease until someone showed up and said, I need dialysis. And we just heard that sort of theme from Margaret. The other idea is that caregiver involvement was really influenced by what the system truly needed. So this was sort of very nicely expressed in a few quotes in the paper that looked at, well, if the patient was doing well, wasn't frail, was driving themselves to the appointment, I sort of like didn't exist. That's where the title of the paper comes from. Maybe they don't know I even exist. And as that patient progressed and got weaker and couldn't drive themselves to the hospital, all of a sudden, the role of the caregiver changes. But it changes based on what the system needs and not necessarily based on what the patient needs. And there was tension and conflict, which you heard just directly from someone about, well, I need to stop. I've had enough. And then there's this tension and conflict between living and how to live or what kind of life one should live. There's even reports of conflict between patients and doctors about, well, if you don't want to start dialysis, let me talk to your caregiver and maybe I can have them convince you that that's the right thing to do. So this is a normal, natural kind of tension that exists in renal care. And the last part of the talk is how we can do better. And so I want to introduce palliative care to all of you as someone who practices it and as really a nephrologist who has sort of drank the Kool-Aid, if you will, of palliative care. There's substantial amounts of misconceptions about palliative care. I want to try to clear some of those up. And there's a lot of distrust about hospice. This is not really a talk about hospice, but this is a talk about what the philosophy of care is and when you should think about this as a patient, as a caregiver, and as a provider as well. So palliative care is specialized care that treats the symptoms and burdens associated with any serious illness. It doesn't have to be a terminal illness, but any serious illness. It's delivered by a multidisciplinary team. Nurses, social workers, chaplains, psychologists are frequently part of palliative care teams. And palliative care is not the same thing as hospice. So before I get into the distinctions between palliative care and hospice, what exactly is palliative care? What do? We treat distressing symptoms. We help patients outline goals and preferences. So that's the slide that I showed earlier with the multiple blue bar graphs. We help increase the numbers of patients who are willing to engage in conversations about those topics. We support spiritual needs and beliefs because oftentimes those remain unexplored and can really dramatically affect care. And we address caregiver needs as well. The caregiver becomes almost our patient. So what is the difference between palliative care and hospice? Palliative care can be appropriate at any stage of an illness. It's distinct from geriatrics in the sense that we don't just care for patients who have advanced age. We don't have an age cutoff. So for example, some of our most frequently seen patients in the hospital are young patients between the ages of 20 and 40 with some serious cancer, leukemia, lymphoma, any kind of metastatic solid cancer. So those patients will not be seen by geriatricians because they're too young. So our work is different from geriatricians. Hospice, on the other hand, is really a philosophy of care that addresses patients who have a terminal illness. Oftentimes we think of terminal, at least in this country, as being a prognosis of 6 months or less. And the philosophy of care shifts from curative therapy, like chemotherapy or heart catheterizations or dialysis, and it shifts to symptom management. And hospice care can include dialysis care. That's a topic for a different day, but just to be clear, dialysis does not mean that somebody cannot receive hospice. So the goal is really to replace this struggle that we talked about earlier, the themes that we talked about between patients and nephrologists, with a model of care for any serious chronic illness that looks like this. So the idea being that patients with a serious illness would receive curative treatment throughout the time when it was felt to be medically appropriate. But over time, as their curative treatment began to have less benefit, there would be more involvement of palliative care in their treatment. Now, this is not really drawn to scale. So for most patients, hospice would not be this long of a period. But just so I could write the word and show it to you, I've made it this long. Hospice would be a narrow slice of this graph, and it basically would be sort of end-of-life care. And very importantly, bereavement care is very important. So after a patient with a serious illness dies, it becomes our duty as hospice providers to care for patients and their bereaved loved ones. And shifting away from hospice and back to palliative care, the goal of palliative care for any serious illness is to facilitate what we call advanced care planning, which is a term I'm guessing most of you have heard of, but it's sort of jargon for having a series of ongoing conversations with patients about their preferences. Just because a patient has a living will or an advance directive doesn't mean that advanced care planning is somehow magically completed. People are allowed to change their minds. Their situations can change. Preferences can change. So this graph really shows how, with different illness trajectories, advanced care planning can be ideally implemented early, before decline, so that conversations about your future or your loved one's future seem like they're proactive conversations about preferences and not necessarily reactive conversations that seem like they're dismal and all doomsday. So the idea really is to have these conversations not in moments of critical illness or not in acute hospitalizations, but to have these conversations when they feel a little uncomfortable and they feel like it's not the right time to be having these conversations. Those are actually the right moments to bring up these conversations. And part of my role is to help nephrologists feel more comfortable initiating these conversations. And so improving kidney care, I see it sort of in four ways. We can emphasize advanced care planning more. We can help nephrologists communicate better. And we can include patient-reported outcomes into our work, because that's very important. And we can also pivot towards providing more high-value care. One of the most disheartening and skeptical and humorous things that I heard from a senior mentor was, he said to me, Amar, you know, we are in the business of failure. When kidney failure happens, we take care of it. And that's how we make our living, is on failure. And I thought that was both amazing, incredible, sad, and happy at the same time. And I think the patient the healthcare system reimbursement models are changing over time so that we don't just do more, we do what's more efficient and what's better for the patient. So over time, I think over the next few decades, we might see a change in how we provide care that's going to force points 1, 2, and 3 much more onto the system. And so if I have some time left, I want to talk about something that I do, which is renal supportive care, and what that means. So you all have heard the term. And we already heard this earlier, but the way this is taught still to nephrology fellows around the country, oftentimes, not always, is if you have advanced kidney disease, you have 3 options. You have kidney transplant, which is the best if you're the right age and don't have any reasons not to. You can do PD, or you can do hemo. And there is a 4th option, and the 4th option is death. And what I want to change about this sort of way of speaking is the idea that the 4th option is not really death. It's renal supportive care for adequately selected patients. And I don't have the time to get into that in too much detail, but I'll try and speak to you guys just for a few minutes about who might be a candidate for renal supportive care. So just a quick aside in terms of data, and these are data from the Netherlands. And basically what they looked at for 10 years were patients who were 70 or older. And these are all patients who had pretty advanced chronic kidney disease. And 1/3 of them chose renal supportive care. This is a very different practice environment than the US, where 1/3 of these patients are actually opting out of dialysis. That number is less than 10% here. So it's already dramatically different from our practice setting. And the other 2/3 chose dialysis. And they got full medical care. The ones who didn't choose dialysis were not cared for in a hospice manner. They were cared for with a nephrologist, with a nurse, a social worker, and a registered dietitian. And they got aggressive, non-dialytic management of their kidney disease. And so this is interesting because it would be nice to know what happens to these patients when they have severe renal failure and they would otherwise need dialysis. how long do they live, what's their life like. And so patients who chose renal supportive care were understandably older than the ones who chose dialysis. So the mean age was 83 years old for people who chose renal supportive care. Overall, patients on dialysis did survive longer, but there was no survival advantage, almost statistically significant, for patients who were 80 or older. And if you do some statistical analysis and look at just the subset of patients who had high comorbidity scores, survival even at age 70 was reduced with dialysis. So the idea here is not to say that, oh, this is fine, we should adopt this across the board. The idea here is just to spread a simple message that not doing dialysis, not for one individual patient, but for a cohort of patients, not doing dialysis when we would normally start it doesn't necessarily mean that someone will die right away. Not initiating dialysis for some people can mean that they can be medically managed for quite some time. So it's important to have that discussion in a much more informed way with elderly patients as they approach that point. So from that study and from a couple others which I'm not sharing with you today, people around the country have thought about who is appropriate for renal supportive care. And this is a moving target, and I invite some discussion about this at the end of the talk. But people who are over 75, who have, in addition to that age cutoff, who have frailty, who have heart disease with a reduced ejection fraction, or any other existing condition like metastatic cancer that can limit their prognosis, are ideal candidates to actually have just a discussion about life not with dialysis, about not initiating dialysis. There are other individuals, regardless of age, who may say, I want to maximize my quality of life. Quality matters more to me than quantity. When you press people to that, I find in my limited experience that this is a very rare group of people, that most patients, unless they're truly suffering with untreatable symptoms, tend to lean towards the side of quantity first. And then if that doesn't work, then we can go back and have this discussion again a second time. But it's important to at least start that discussion so patients know that this is not a one-way street, that when we start dialysis, it doesn't mean that this is going to be the rest of your life. And for patients who think dialysis would negatively impact their quality of life, this is also a reasonable choice to offer them. And presence of geriatric syndromes. I can't tell you how many times nephrologists feel discomfort and anxiety seeing patients who are weak and frail, severe dementia in nursing homes who are on dialysis, and we don't feel empowered to start conversations. So having conversations with patients' families who have advanced dementia or other geriatric syndromes is quite important. And very briefly, you might be wondering, well, what exactly does this look like? What will you be doing in a clinic that does renal supportive care? So what we do is we tend not to focus so much on numbers and on meeting sort of evidence-based guidelines on goals, and we tend to focus on controlling symptoms so that quality of life is maximized. So for example, blood pressure control might often translate into a systolic target. In a renal supportive care clinic, we would control blood pressure to avoid symptoms, to avoid headache, to avoid volume overload, to avoid shortness of breath. If that means somebody's blood pressure is 155, we might tolerate that. Dialysis catheters are a big no-no for all nephrologists, and for me as well. But for somebody who's, let's say, 85, who really wants to try dialysis, who's fully functional, they have a high rate of fistula non-maturation, meaning if they had a fistula placed, it may not work. So trying dialysis with a catheter for a few weeks to see how it goes is not necessarily the end of the world. So that right now in today's climate, that's like heresy, and I'm sort of embarrassed to even say it out loud, but this is a direction that we could be taking. There's no evidence to support me saying that, but there's a lot of evidence supporting the first part of the statement, which is that the fistula may not even work in the first place. And the second aspect of this is that in general, symptom management sort of takes the front seat, and biochemical optimization takes the back seat. And what the end result really ends up being is we end up reframing this fourth option. We don't talk about it as death. We use different language, and we say things like, we will still take care of you. the nephrologist will not go away just because you don't choose dialysis. We still have expertise to offer you and your loved one. We'll help manage your symptoms with medicines. We'll avoid surgeries. We can try dialysis for a short while. And we can talk about how you want to be cared for if you got sicker. And then we can talk about hospice when it gets too difficult for you to even come to clinic. And overall, what we hope to achieve by integrating some of these palliative care principles into nephrology is enhanced symptom control, more patient-centered care, more advanced care planning, and really a less intense end-of-life experience. So in summary, sort of the take-home points from this morning are elderly patients make up a large percentage of those living with kidney disease. I think most of you knew that already. But kidney disease causes many symptoms and results in impaired quality of life, and patients feel underprepared for life on dialysis. Advanced care planning can help with that, and palliative care principles can improve kidney care. Thank you for your attention.